All right, welcome everyone. We continue with our discussion to destroy the pulmonary and critical care system. We're gonna know everything about it. We're gonna master it. We're gonna get every question right. So this is what you want to do. Okay, so you have a patient who's 86, came in because of respiratory distress, confusion, lethargy, started this morning. Okay, your exam shows crackles, irregular tachycardia. So crackles, irregular tachycardia, there is left femoral neck fracture as well. And then, so what would be the best next step in this patient? You do supportive care, okay? So why is that? Why there is a supportive care for this patient? What is going on in here? This patient had left femoral neck fracture, caused them to have confusion, crackles, irregular tachycardia. This is mean there's fat embolism syndrome. See, so fat embolism syndrome, what other causes that? What causes that? Long bone, pelvic, and other marrow containing bones fracture. Okay, this is one thing. Other thing, orthopedic surgeries can cause that as well. Pancreatitis can be causing sickle cell disease. Okay, how does it present? Presents usually 24 to 72 hours after the injury or insult. And then you have classic triad: respiratory distress, hypoxia, dyspnea, tachypnea, or some acute lung injury requiring mechanical ventilation. That's number one. Second thing, neurologic finding, altered mentation seizure, like in this case. Confusion, crackles, confusion, distress. That's the second thing. Third thing is petechia. So respiratory distress in 95% of the cases, neurologic is 86% of the cases, so it's always there. Petechia in 20 to 50% of the cases, you can see petechial rash like in head, neck, thorax, axilla, subconjunctiva. You can see that. You may or may not see that. How do you treat it? You treat it in early immobilization or fracture and operative correction. And then supportive care, really. It's just like, it's not like there is a clot that you can do anticoagulation, right? It's not what the regular PE or so, this is embolism. So this is fat embolism, not clotting factor embolism, clot or so. Okay, now you get another case. He's 42-year-old man, came in with nausea, vomiting, abdominal pain, okay? You do x-ray, shows bilateral infiltrate and a new small bilateral pleural effusions, okay? So bilateral infiltrate, bilateral effusions. What would you do in this case, okay? And you do in the blood, in the sputum culture, grew candida. Alright, so this patient, what do? You start antifungal or not? That's what the question is asking. The treatment is no antifungal. So why is that, you may ask? Okay, so the growth of candida from respiratory secretions rarely indicate invasive candidiasis and should not be treated with antifungal therapy. If it was in the blood culture, that's a different issue. You have to check eye exam, you have to start antifungal, that's serious stuff, right? But if it's in the respiratory secretion, it's okay, it's not invasive. Okay, especially if the patient's doing well clinically. 65-year-old woman, okay, comes in with dyspnea on exertion and decrease the breath sounds on the right, decrease the breath sound and dullness to percussion. What does that mean? Maybe there's pneumonia going on? I don't know, maybe. There is a blunting of costophrenic angle pleural effusion, so we did thoracentesis, right? And 750 ml of serous fluid is removed. So what would you do in this patient? So pleural fluid analysis is important, so you want to know, they give you pleural fluid analysis and you want to know how to interpret that. Very important, okay? So fluid shows total protein 3.2 and albumin 1.8, okay? LDH 60, okay? Leukocyte 500. What is that? What is that? What kind of fluid is that? And then they will ask you what caused that, what's diagnosis, okay? So here is what we could do for this patient. There are common causes for pleural effusion, there are transitive, there is one exudative. Okay, so now our goal is to identify, is it transitive or is it exudative? So how do we know if it's transitive to exudative? You do fluid protein to serum ratio. If it's more than 0.2, 0.5, that's 1 point, mean possible exudative. If the pleural fluid pleural fluid per LDH more than divided by serum more than 0.6, if like the pleural fluid LDH higher than the serum more than 0.6, I get not higher, like more than half the serum, this indicate maybe there's exudative. Okay, pleural LDH more than 2/3 upper normal level of LDH. So you want to compare it. So here we need the serum LDH. Okay, so if I tell you the LDH is 95 and this LDH is 60, so that's 1 point, could be. Total protein 3.7, this one 3. So this is not quite more than 3. Okay, so this makes it less likely to be exudative. So this one mostly transitive, so you want to do this could be CHF. Other cause of CHF like cirrhosis, nephrotic syndrome, peritoneal dialysis. Exudative effusion, there's infection, talking about infection, malignancy, connective tissue disease, movement of fluid from abdomen to pleural space, cabbage, pulmonary embolism, talking about big stuff, you know, cancer, infection, you know. But transitive, this is like nephrotic syndrome, cirrhosis, CHF. It's still big stuff, but you know, different kind of big stuff. Alright, so this is the case that we talked about. Okay, now we have another patient came in with 57, came in with cirrhosis, and then 3+ pitting edema to thighs bilaterally. Okay, what would you do for this patient? What causes? And then you check the acid-base disturbance. This is like a acid-base disturbance situation. They give you a pH. And PaO2, they bring you the PaO2 of 96, PCO2 of 28, okay, pH of 7.48. So what does that indicate? pH 7.48, PCO2 is 28, so low, so this is respiratory alkalosis. So what causes respiratory alkalosis in patient with cirrhosis? That's what they're asking you. Okay, why? So what would be your answer in this case? So in cirrhosis, there is a progesterone accumulation, right? So this causes increased central stimulation of ventilation. So it's opposite to COPD. Cirrhosis opposite to COPD, okay? Causes high respiratory rate and low PaCO2. Okay, now we get another patient, 62-year-old, comes in with the emergency department with fever, chest pain, shortness of breath, cough, and then you do CT. CT shows 1 centimeter cavitation and multiple nodules surrounded by ground glass infiltrates. And they tell you what is the diagnosis, what could be causing that in this patient. This one is aspergillosis. It's very heavily tested, aspergillosis, for some reason. This is aspergillosis. And why is that? Why is it aspergillosis? Okay, here's why. This is called actually invasive pulmonary aspergillosis. Usually risk factors are solid organ transplant. They bring a patient to have solid organ transplant or neutropenic after chemotherapy or have steroid therapy because of rheumatoid arthritis or so, immunosuppression if there are AIDS, you know. And they have tried cough, pleuritic chest pain, and hemoptysis. And then CT shows nodules with a ground glass opacity. It's called halo sign. And cavitation with air fluid level, and biomarker galactomannan, beta-D-glucan, and sputum sampling for fungal stain and culture. That's what you do. And then you treat it with what? Voriconazole and a reduction of immunosuppressive regimen. You do surgery as well if needed. So it's a good idea to involve pulmonary as well. Okay. Now we have another patient so the patient is in respiratory distress, okay, ARDS, on a ventilator, and they're asking you what's benefit of dialysis, what benefit of diuretics in this patient, okay? So this patient, this positively affect, ventilator benefit, okay, ventilator 3 days, or it decreases the time that you need the ventilator for. So because when you're on a ventilator, you need to do a few things, okay? You want to maintain mean arterial pressure more than 60 without pressors. You want to have urine output more than 0.5 millimeter per kilogram. Say if somebody 50 kilogram, you want to do 50 ml per hour. So in 10 hours you want to 500 ml, okay? So if they're dynamic in urine, that's not a good sign. Central venous pressure, you want more than 4 millimeter Hg, or pulmonary air pressure more than 8. And effective circulation, you want a cardiac index more than 2.5, or capillary refill time less than 2 seconds. If the patient have any of that, then it's okay, use diuretics, okay? If the patient does not have any of that, you can do fluid boluses, okay? So basically, in summary, if someone making good urine output, MAP is good, cardiac index is good, pressure is good, give them diuretics. This is going to help them get off the ventilator quicker. If their pressure is low, urine output is low, then central venous pressure is low, all the cardiac index is low, all the indexes are low, give them fluid boluses, okay? This is important to help manage them. Alright, now we have another patient. So they bring you x-ray tube more on the right, more to the right. So what would you do? Pull endotracheal tube out. Reposition or reposition the endotracheal tube. This is going to help the patient breathe better, absolutely, okay? So now the patient, this one is interesting case. So like they say, they bring 52-year-old guy, woman, whatever, had cardiac arrest, and then while you're resuscitating, you're doing all good stuff like the intubation. Patient was intubated, chest compression, all of that, and then you have sudden rise in capnography to 38 mmHg. What does that mean? What sudden rise in EtCO2 capnography mean? This means return of spontaneous circulation. So this what they want you to know in this question: sudden rise in end tidal CO2 is the earliest indicator of return of spontaneous circulation in patient with cardiac arrest undergoing cardiopulmonary resuscitation. It even comes back before the pulse comes back. Okay, so that's a good sign actually. Alright, so now we have this patient. We have 70-year-old woman, came in with cough, and you examine her. There's diffuse wheezing, okay? There's diffuse wheezing, cough. You started, so she had COPD, hyperinflated lung, okay? Emphysema, COPD. You gave steroid and all of that. PCO2 70. What's the best next step? Then you want to do BiPAP for this patient, okay? Because PCO2 is elevated, then this is COPD, BiPAP. And because this one of the indications of BiPAP, we said COPD, pulmonary edema, respiratory failure, postoperative hypoxemic respiratory failure, you can do that. Facilitated early extubation. So these are the four main indications for BiPAP. We talked about that. And then you don't do it if somebody medically unstable, inability to protect airways, there's mechanical issues, These are like the BiPAP. Alright. Now another case, kind of tricky, is important as well. And they bring you a 55-year-old undergoes a bronchoscopy for persistent cough like hemoptysis. On exam, so hemoptysis, undergo bronchoscopy, you give local anesthetic and some sedation. After that, the patient develop hypoxia, okay, central cyanosis, myoclonic jerks. What the hell's going on? This is pretty serious stuff. What's your diagnosis? This is serious stuff. The patient could die. This is methemoglobinemia. Okay. Now this brings us to the discussion. What is the presentation of clinical methemoglobinemia? Usually history, you have someone with dapsone, nitrate, or topical topical anesthetics. Okay, like in this patient. Usually you have cyanosis, hypoxia, oxygen around 85, dark chocolate colored blood. This is another clue. Another clue, saturation gap, more than 5% difference between oxygenation saturation on pulse oximetry and ABG. And normal PaO2, that's what give it away. Normal PaO2 with hypoxia, this could be methemoglobinemia. So this is important to look for.